Thank you. Very grateful to be out here today talking about a subject that's very important, that's very commonly underlooked as well in sleep. I always talk about disclosures. I have no conflicts of interest to disclose. I receive no funding through pharmaceuticals. I am employed by Lee Memorial Health System. I am an author and have a website that provides sleep health information, so the masses are able to get this information as well. Caring people, caring for people. And I always say that if I have one conflict of interest, it's that I am a father and I am a husband, and I hope that with every talk that I give and book that I write, that it helps make this world a better place for them.
All right.
So Asclepius was the god of medicine in ancient Greek religion. And his symbol remains the symbol of medicine today. But with this, his symbol consisted of a non-venomous snake that was used in healing rituals. And these snakes would slither around the dormitories where the sick and the injured slept. These temples were the first annotations, were the first documentations of hospitals. And interesting, they didn't go there for medications, but they actually went there for sleep. Now, in this proud profession of doctors teaching doctors that has gone through many generations, somewhere down the line, the teaching of sleep was kind of a little bit left behind, but we're changing that now. So I call this 5 things that many docs don't know about sleep, but it's really 5 things that many people don't know about sleep. One is that nobody sleeps through the night. Another is that an untreated sleep apnea can be as dangerous as smoking. Narcolepsy commonly presents in youth or as insomnia. Medications are actually not first-line treatment for sleep, and sleep loss equals weight gain, and we'll touch about all of these. So I like to talk about how I actually learned about sleep. In my medical school training, I received one lecture on sleep apnea, and I received another lecture on medications for sleep. Now, in my primary care residency, in my pediatrics residency, I received no lectures at all about sleep. I also have a master's in public health, and in my master's in public health, I never received one course on sleep or not even one lecture or talk on sleep. And now you may be saying, what qualifies me to be here today talking about sleep? I ended up doing a neurology with special qualifications in child neurology fellowship at Vanderbilt. And over there, the Department of Sleep Medicine was through the Department of Neurology. And I got into it then, and I loved it and haven't looked back. It's been great. And it's interesting because I originally went to medical school to be a general pediatrician. That's what I really wanted to do. However, at the time, I found it difficult to give parenting advice when I wasn't a parent. So I ended up falling in love with neurology, and I chased it. And so too, my finding of sleep medicine was very fortuitous. Now, over the next couple years, I joined many different organizations and continued different medical educations to continue learning about sleep. And most recently, I've also been trying to join non-sleep organizations to learn more about self-regulation skills, reducing anxieties, and ways to help people be able to sleep. And it first started through hypnosis and then later through mindfulness and mindfulness-based stress reduction. And I'm currently starting a new journey of just learning about nutrition for the first time, actually. Nutrition and wellness in general. So what is normal sleep? Now, there's a lot of silent epidemics that are out there, but sleep loss is not a silent epidemic because snoring is very loud. And also, when people are posting and talking about how they can't sleep, hey, it's out there. But interestingly, when we were born as babies, there was a couple things that we just knew how to do: to feed, to digest, and to sleep. And let's learn a little bit more about that today. So this is a normal night's sleep, and just like a washing machine has cycles, our sleep has cycles, and this is going to make sense, okay? So before you go to sleep, you are awake. You see, I told you, it makes sense. At the end of the evening, we're awake. And like I said, nobody sleeps through the night. There are some awakenings that occur every single night, and this actually has a name called NWAC, or number of awakenings. And if someone wakes up 4 or 6 times in an evening, that's actually normal. And some people have proposed 10. And this goes back to our caveman days where you'd wake up, look at the fire, okay, there's no saber-toothed tiger, and kind of go back to sleep there. So these are important concepts to know here. Now, we have this cycle called REM. And just like a washing machine has an active rinse and spin, we have this active sleep period called REM. And many people think it's our deep sleep, but it's not. We are dreaming, but there's a lot of brain activity going on. We're taking today's information and we're storing it into a long-term memory, which is why if you remember a dream, you may have a dream of someone you haven't seen in 10 years or a place that you were just in maybe a day ago. Now, when we dream, our body is paralyzed, and that's a good thing because it protects us. Okay, I have a 6-year-old boy, and he doesn't dream that he's sitting still at school. He's dreaming that he's in a bounce house, and if we don't have that REM paralysis, he'll crack his head. Now, in this dream period, in this REM period, we're also learning to associate these dreams with emotions as well, which is why you may wake up and say, oh, that was a good dream, or oh, that was a bad dream, the opposite. And we don't just dream the second that our head hits the pillow. It normally takes about 90 minutes for our first REM period to come, and then every 90 minutes afterward we have another REM cycle. So once again, just like there's an active rinse and spin on a washing machine, there so too is an active dream period over here. Now, we have this other stage of sleep that's not REM, and this is where the terminology gets a little bit more complicated. It's called non-REM. All right, good. I haven't lost anyone yet. And we cycle in between these throughout the entire evening. And just like a washing machine has a deep soak at the beginning, we have this deep sleep at the beginning where our brain waves are really slow, and that's what it's called, deep, slow wave sleep. This is the part that growth hormone is secreted. It's also the part that refreshes you so that you have good short-term memory. We talked about REM sleep helping with long-term memory. Our deep sleep helps with short-term memory and working memory the next day. Now, interesting, because our brain waves are so slow during this period of time and our brain activity is so slow, our body's not paralyzed. But we're not brain dead. If you have a thought, you may say it, sleep talking, or think of a place and walk there, sleepwalking. And that's where a lot of these somnambulism, parasomnias, or sleepwalking and sleep talking occurs. And as kids grow up, they've grown, they need to secrete less growth hormone, they don't get into as deep of a sleep, which is the reason why we outgrow some of the sleepwalking and sleep talking over time. So how much sleep does someone need? And that really is variable for everyone. And the example that I give about variability is that I say that I weigh probably twice as much as my wife does, but she eats more than I do. You can't tell me that our metabolisms are the same. And the same thing with sleep needs. Everyone has different sleep needs. However, I like things that are easy to remember. And something that's easy to remember is a 12-month-old should get 11 plus 1, 11 hours of sleep plus 1 nap. A 10-year-old should get about 10 hours of sleep. A 9th grader through high school should get about 9 hours of sleep. When you have your 8 to 4 job, those 8-hour days, 8 hours of sleep, and then into elderly, into 70s, about 7 hours of sleep, and it's normal to reintroduce a nap. But all of these vary plus or minus an hour. So how can this change my practice? How can this information today change my practice tomorrow or our habits of tomorrow? Well, one is identifying if someone's having difficulty sleeping, yourself or a patient, where is it that they have difficulty sleeping? Is it at the beginning where they may have a sleep onset insomnia? Do they have a sleep disorder that's causing their sleep to be fragmented? Or do they have night awakenings that it takes them time to get back to sleep, or maybe even some circadian disorders? So identifying first where the problem of sleep is. So we talked about what's going on at night. Now let's talk about what's going on in the daytime as to what makes our sleep drive. Get it there? Sleep drive. So our body and our environment interact on our brain to help us sleep. Our body, it's called the homeostatic process, and the names are not important, but the concept is anything that uses energy creates a waste product. If you put gasoline in your car, the waste product is going to be exhaust. Make sense? So our brain utilizes energy. Again, names are not important, but it utilizes glucose as energy, and it creates this waste product called adenosine, which is the exhaust. And what happens is, as time goes by, the day goes by, you accumulate that exhaust, and that leaves you exhausted, which is why it's hard to sleep, which is why it's hard to stay awake past a certain time. That's why we feel fatigued after dark. Now, interesting, that deep sleep that I mentioned is the part that washes away the exhaust, the part that washes away the adenosine and refreshes us. This is also why if someone's taking, let's say, a really long nap or a really late nap, or they're sleeping in later, this is why they may not be tired in the evening. So an analogy that I give is, again, I have a 6-year-old boy and a 3-year-old girl. I don't give them candy before dinner. Why? Because they're not going to have an appetite for dinner. Well, long or late naps or sleeping in excessively on weekends, that's like sleep candy, and makes it so that you have difficulty getting to sleep later. Also, caffeine counteracts that adenosine. Caffeine counteracts or it gives you the opposite effect as the waste product. So that's why it helps make you alert, but that's at 200 milligrams and below. At 300 milligrams and above, what it actually starts to do is starts to agitate your anxiety receptors there, which is why you may get kind of jittery there. So know what you're putting into your body. So now we have this process of our environment that our own body makes melatonin, and all day long the light is coming into our eyes and not letting that melatonin come out. But then the light goes away and bam, our melatonin comes out. So what we have is this process where we accumulate this exhaust at the same time that the light goes out and the melatonin comes out, and that's what causes our sleep onset. But sometimes we can get that kind of chopped up there. And if someone's waking up early, you can see that they've accumulated a lot of that exhaust, but it may not be time appropriately socially to sleep, and we can have some sleepiness in the daytime. Or another problem that could be happening is that you're sleeping in later your environment says, hey, it's time to go to sleep, but you haven't accumulated that sleep drive, so you'll have difficulty with getting to sleep. Now, one thing that's important to know is that when an adult is tired, they yawn. But when a child is tired, they tantrum. And no one tantrums like my baby girl there. When teenagers are tired, they're just flat out obnoxious. So what can happen is sometimes we can get our days and nights mixed up through the weekends, and we may actually be jet lagging ourselves. Now, jet lag is not that you got into a plane and all of a sudden you're tired. No, we just talked about how we have this 24-hour internal clock, and then now you get into a different time zone. And when someone has jet lag, the symptoms are fatigue in the daytime and difficulty getting to sleep at night. And it generally takes about 1 day to adjust for every 1 hour time zone that we shift. So if someone goes to California, that's a 3-hour time zone change. It's going to take them 3 hours to adjust. They'll be tired in the daytime and difficulty sleeping at night for 3 hours. Well, what are many of us or teenagers or young adults doing when they wake up at a certain time during the week and then they're staying up 4 or 5 hours on the weekends? They're jet lagging themselves 5 hours, and then it's going to be 5 days of difficulty with getting to sleep at night, fatigue during the daytime, interfering with school or work. Now, and then those 5 days go by and then they're doing it again. Normally when I talk to teenagers, I give this information and, oh, okay, they're nodding their head and they get it and they realize kind of what they have to do. Except one time I had a teenager that looked at me in the eye and told me he didn't believe me because he didn't believe in time travel. So how can this information today change my practice or habits for tomorrow? Understand that if we want a regular sleep time, we have to start with a regular wake time. So what are some effects of sleep deprivation? You know, briefly, we can have some problems with not feeling restorative or non-restorative sleep, not feeling refreshed, and that can give us some irritability or concentration issues. But also, we could end up in a pro-inflammatory state that can affect us anywhere from our immune system to our risk for diabetes or heart disease. And sleep deprivation can cause ADHD symptoms, both in children and adults and in the elderly as well. And that's not me just saying that, it's the NIH. So let's talk about some sleep disorders. What is sleep apnea? Normally, you have plenty of room for the air to flow, but sometimes as you're trying to breathe, you can see the effort here, the air isn't moving through, it's obstructed. And what can happen is either the oxygen can come down or it can disrupt the quality of sleep. And remember, I said that waking up 4 or 6 times a night may be normal, but if this is happening 4 or 6 times every hour, then that's causing a stress and causing non-restorative sleep. In children, many times it's the tonsils and adenoids. Now, 2% of children, 2 to 3% of children may have obstructive sleep apnea. However, 10% of children have something called primary snoring, which means that there is some snoring, but the air is moving through. So this is why we don't just take everyone's tonsils out anymore, because we need to determine whether or not they have a sleep apnea or not. Because if they have the primary snoring, many times as time goes by, the tonsils do shrink, and as they grow, the airway matures and they can outgrow that. In adults, it's a different area, what I scientifically call the back of the throat space there, that becomes obstructed. And there are many treatments for sleep apnea, many treatments. But for the sake of just understanding the impact, we're going to talk about one, which is called CPAP. And CPAP is pressure that opens up your airway. And you can see that this airway is collapsing, but the pressure is cushioning the airway there, splinting it open. And different degrees of CPAP, different pressures open it up a different amount. And that's why many times we do what's called a CPAP titration study to find out what's the right pressure. Now, up above, we have an untreated sleep apnea, and right below, we have the same patient when we actually do treat it. And you could see that when you treat it, there's a lot less of the oxygen coming down, a lot less arousal. Remember, waking up 4 or 6 times a night is normal, but up top, this person's doing it 4 or 6 times every hour. The patient initially didn't have a lot of REM, and then we gave them the CPAP, and bam, they get this REM rebound there. And then also more of the deeper sleep, of the non-REM sleep as well. Less snoring. You get rid of the apneas or the stop breathing events. And that's why we do the titrations, to find out what's the right pressure for that particular patient. Now, interesting, this patient up top, they didn't come to me for sleep apnea or snoring. They actually came to me for insomnia. And what was happening is that on a nightly basis, he wasn't sleeping well. He didn't know he had an untreated sleep apnea. He just knew that he wasn't sleeping well. Well, if you know you're not going to sleep well, then you're going to have difficulty getting to sleep. And what was happening is that he said that his Valium wasn't working for him anymore. But actually, the Valium was making his airway worse and was causing more problems to the sleep apnea. When we gave him the CPAP that first night, he slept great. And ever since then, he knew that he was going to sleep well. And it got to the point where he would put the CPAP on and his mind would just kind of melt into the pillow there. And the prevalence of sleep apnea in males from 30 to 60 years of age is actually 25%. That's pretty high. And the prevalence of sleep apnea after 60 years of age or after menopause starts to become the same in males and females. And with an untreated sleep apnea, you can have high blood pressure as well. And you can see these blood pressure spikes here. But let me just show you literally. So right here, this patient, before they go to sleep, their heart rate is below the 80s. And then when they have the stop breathing events and the oxygen comes down, look how the heart spikes above the hundreds. And then we give them the CPAP, and look how the heart relaxes down into the 60s. So this isn't to scare y'all, but this is how untreated sleep apneas cause strokes or heart attacks and also lead to high blood pressure. And that's what we see, is untreated sleep apneas cause multiple types of cardiovascular disease and puts us in pro-inflammatory states as well. And an untreated sleep apnea can have some of these same heart effects that smoking has. So how can this information change my practice today? One, ask your patients or ask yourself, do you snore? Unfortunately, not everyone's so honest. This guy doesn't snore, he dreams he's a motorcycle. But what we can do is ask a couple more questions. And here we have a stop bang, And in Epic, in our computer system, we have a dot phrase called dot stop bang. Are we snoring? Are we tired? Has anyone observed you stop breathing? How's your blood pressure? Is your body mass index 35 or greater? Age over than 50? Neck circumference 17 inches in male, 16 in female? And then gender, are we male? And if you answered yes to 3 or more, your risk of sleep apnea is increased. Now that's not the only thing that we look for. Sometimes we also look for legs as well. And restless leg syndrome are uncomfortable sensation in your legs. They're worse at night, they're worse when you rest, and they're relieved by movement. And that's a clinical diagnosis of which we may find FDA-approved treatments, but we also may find that someone can have iron deficiency or kidney issues or venous insufficiency. So potentially we can find medical causes of this. As opposed to something called leg movement disorder, that sometimes these legs continue to move at night, and sometimes people's legs are moving at night and they're not aware of it. And this may be an issue, it may not be. And that sounds vague, but let me just show you. So here, this person's legs are kicking all night long, but it doesn't cause any disruption to their brain. As opposed to this person, where the leg movements are either frequent or forceful enough to where it does cause disruption to their brain. And 75% of these, when their kids can have ADHD symptoms or adults can have symptoms of fatigue or non-refreshing sleep. So how can this information change my practice tomorrow? Always ask ourselves, what are we treating? Some of these over-the-counter products with antihistamines, they may make leg movements worse. The Valium with the other patient was making the sleep apnea worse. Melatonin isn't going to address either of these. And then sometimes we may have difficulty sleeping actually because we have narcolepsy. And that's a good segue. What is narcolepsy? So narcolepsy is not just a disorder of sleepiness, it's a disorder of REM. And if we remember, in REM, our body is paralyzed, we're to protect ourselves, we're dreaming, and we're learning to associate these with emotions as well. And also important, your first dream period normally doesn't come until 90 minutes. So now let's take a look at the symptoms of narcolepsy, which could be sleepiness, cataplexy, all of these symptoms. We'll look at them one by one. So sleepiness, hey, it's normal to fall asleep during a mundane time, but when you're actively trying to make your way and sleep is intruding, that's a problem. So that's REM kind of coming into your daytime there. Cataplexy, the stereotype of what cataplexy is when someone completely collapses. But that's a stereotype. More common is with a strong emotion, it triggers their brainstem area for the muscle tone to become lower, and we can have facial sagging, slurred speech, jaw weakness, a head drop, or a feeling of your knees kind of buckling there. And that can happen with anger, laughter, or any type of emotion. Sleep paralysis. Being awake, you know you're awake, but your body can't move. Now, some people can have this called recurrent isolated sleep paralysis, and many people have had this at one time in their life, but patients with narcolepsy have this a lot more commonly. And now we understand that it's that REM, low muscle tone, coming into your daytime. Or hallucinations. And it's not hallucinations from psychosis, no, it's a dream while you're awake. And these hallucinations can be vivid. And I've seen people say that they've seen spiders, lava rocks. One person said he saw a lion one time. Another kid that I saw said that he saw midgets laughing at him. You know, so these could be very, very vivid in description. And also, one of the common symptoms of narcolepsy is disrupted sleep or insomnia. And you can see that at the bottom we have a normal night's sleep that we've showed you, but the patient up top, just like you have REM coming into your daytime when you have narcolepsy, you can have wake coming into your REM, and you have this disturbed sleep. And 50% of patients with narcolepsy complain of disturbed sleep or insomnia. And demographics-wise, the mean onset of symptoms of narcolepsy is actually 15 to 19 years of age, 15 to 20 years of age. And when you take a look at the curve, what's the second highest peak? It's before that. It's at 10 to 14 years of age. So there's this term that I really don't like. There's this term called pediatric narcolepsy. And the reason why I don't like it is because you don't have to say wet water or hot fire. It's understood. And narcolepsy actually is pediatric. And what happens is many times a decade can go by before it's diagnosed, and it could be perceived as whether it's ADHD or laziness or mood disorders, and if it's diagnosed. I will say that the pediatricians in this area have been very astute about learning to refer these very early, and we're catching kids at the right time, at the right age range. So the way that you test for narcolepsy is that, yes, you do a sleep study overnight, but if that comes back negative, it's not explaining why you're tired the next day. So what you have them do is that you have them take 5 naps. And the study is called an MSLT, or a multiple sleep latency test. And the name is not important. The concept is that you have them take 5 multiple naps, sleep. How long does it take for them to get into sleep, latency? And we know what normal parameters are, or test. Now, we can directly quantify the degree of sleepiness objectively. And it's not just oh, I feel fatigued. No, we can objectively see how sleepy they are. Now, if you remember, I said that in narcolepsy, that in REM sleep, you normally don't get REM until 90 minutes into REM. If you normally don't get into 90 minutes, should we see it on a 20-minute nap? No. And if we did, that would be sudden, or sudden onset of those REM periods. And that's what we see in narcolepsy, is that we see these patients that we have them take these naps, and they're having REM periods come into these into their naps. So now we see how narcolepsy is a disorder of REM intrusion. And you can see that guy is running fast with an eye, rapid eye movement. I like that one. So once again, now we see this REM disorder, okay? Sleep paralysis and hypnagogic hallucinations in this Gothic painting here. And there's other symptoms that we can have as well. One of them is we can have automatic behavior, which is just kind of doing things automatically, which we all do when we're tired. Loss of concentration. I'll talk about how sleep deprivation can cause memory impairment, which we'll get into, but this actually has a nickname called narco fog. And then also visual symptoms of kind of blurred vision. And what happens is that the muscles from the eyes, of the extraocular eye movements, sometimes with an emotion, they can get kind of weak as well and end up with blurred vision. And then other symptoms that they can have is actually something called lucid dreaming. Well, patients with narcolepsy can have, because they have REM dysregulation, they can have nightmares, but as time goes by, they may develop the ability to realize when they're in a dream. And this is not isolated just to narcolepsy. It happens more in it, but a lot of people can have this. And this is actually something that I'm able to experience, where I realize sometimes when I'm dreaming, and you can do a lot of things. You can change your dreams, fly in them, you can do a lot of things. It's kind of like a little mental amusement park there. But the realization that one is asleep sounds like it's an irony, but it's something that people can use, develop, and has been shown to actually decrease insomnia scores, as well as also post-traumatic stress and a number of different things. Lucid dreaming. So how can this information today change my practice tomorrow? Know when to get a sleep study, but also when we need that MSLT, or also when to refer to sleep medicine, being able to identify these symptoms early. So if we don't have narcolepsy or sleep apnea or RLS, why can't I sleep? And it's a question that I hear all the time, and this is actually the back cover of my book for sleep, because I hear this all the time. I go to sleep and my head seems like it's get plugged into the pillow there. Well, insomnia is more than, okay, you're awake when you don't want to. It could be a difficulty falling asleep, staying asleep, or poor quality of sleep. And it can be associated with distress and some impaired function as well. And 30 to 40% of the population has chronic insomnia at one time. And 90% have at least had an adjustment insomnia, where they go through something and they lose some sleep over it. And importantly, insomnia is a symptom. And that's not me just saying it, that's directly out of the textbook there. So to give an analogy, fever could be a symptom. People don't have a fever disorder. No, they have a fever because they have strep throat or they have Ebola. And giving them Tylenol makes them comfortable, but it doesn't treat the underlying infection. And the same is true with medication sometimes, is that they can make you comfortable, but they're not treating the underlying issues. And It could be from an untreated sleep apnea or restless leg or narcolepsy, as we mentioned, but also commonly we have a tendency to develop something called psychophysiologic insomnia. Now, when that happens, it doesn't mean that we're psycho, but get this. Some people have difficulty sleeping because something's bothering them, and what's bothering them is that they have difficulty sleeping. The more that they stress about sleeping, the more alert they become, and the more kind of exhausted they become there. So, and that can happen to males or females alike, that psychophysiologic insomnia that keeps you awake. Stressing about sleep causes you to stay up longer. So behavioral treatments for insomnia are actually first line through the American Academy of Sleep Medicine. And we'll talk about some of these. Cognitive behavioral therapy. They did this study that it's a landmark study, yet has been reproduced many times, where they gave one group an FDA-approved medication for sleep. And at 2 months, their insomnia scores were lower. But at 2 years, they really weren't much better, and many times people develop tolerance. They gave another group a combination of medication therapy plus cognitive behavioral therapy for insomnia, and they did better with lower insomnia scores than the med group alone. And at 2 years, they did better as well. And then they gave another group no medications at all, and it wasn't placebo. They gave them cognitive behavioral therapy for insomnia alone. And they did better at 2 months with lower insomnia scores, and in the end, they did best overall. And this surprised everyone, in particular the psychologist that designed the study, because what they proposed is that they were trying to show that using cognitive behavioral therapy with medications was going to be better. That was their intent of their study. However, what they found is that the cognitive behavioral therapy alone, or behavioral sleep medicine, was more powerful. So that was the winner there. So one thing that I'd like to encourage is all my psychology colleagues that are out there is to join the Society of Behavioral Sleep Medicine and maintain up-to-date continuing education about advances in behavioral sleep medicine, because it is first-line therapy for insomnia, actually. Other behavioral treatments do include circadian rhythm entrainment, and that's the reason why I start with talking about the environment and our body having an interaction to induce sleep. And there are different ways to do this through light therapy or different types of melatonin therapy as well. Other treatments for insomnia, I kind of lump these together, and what I'll say is that each one of these, sleep hygiene, stimulus control, and sleep restriction, each one of these can be a different 1-hour lecture. And honestly, when I write my books, I write about all of these together. And I'm not saying that to promote my books. I'm saying it because that's how extensive it is, that there's a lot of literature on it. But just to kind of briefly talk about it, I use a concept of sleep association. There's sometimes someone's in their bed and they can't sleep, they're frustrated, they get out, they go to the couch, and they fall asleep on the couch. The opposite happens. Sometimes we fall asleep watching a movie on the couch, and then we go to our room and we're like, now I'm not tired, I walked too fast. And what can happen is that over time you can condition yourself to not associate your bed with sleep, but yet you sleep well on the couch or in a hotel or in other places. So you've learned to associate your bed with I cannot sleep or I don't sleep. And through these techniques, through different techniques, we can improve this. So I commonly get asked about electronics in sleep. What do I think about electronics in sleep? And it really falls into the whole realm of association. One, the light can disrupt our circadian patterns, so that can happen. But more commonly, let's go over a scenario. Does everyone here drive? I'm going to ask some questions they're not hard questions, okay? When you're driving, are you trying to fall asleep or are you trying to stay alert? I told you they're no hard questions. When you drive, do you sometimes listen to the radio? Yes. Can you see how subconsciously you're learning to associate that radio with staying awake? Let me give you a different example. If you ring a bell 1,000,000 times and give a dog food each time, and then one day you ring a bell and you don't bring food out, the dog's still going to expect it, right? And it's not because you fed him the bell. That would be animal cruelty. No. They've learned to understand that that bell means that food is coming. So now once again, you're driving, you're trying to stay alert, you're listening to the radio, you're learning to associate that radio with being alert. Can you maybe see now how, let's say you're in bed and you're not asleep, it may be a bad idea to listen to that same radio station that you associate with being alert. You're not going to let that mind slow down. Well, do people get on Facebook, check their email? Do we get on electronic devices because they bore us or because they engage us? Yeah. So that's my 2 cents there on electronics and sleep, is to try to remove stimulating activity about half an hour or longer if we could before we go to sleep. So stimulus control is using the bed for sleep only. Go to bed when sleepy. Get out of bed if you're unable to sleep and wake up at consistent times. And avoid napping while you're going through bouts of insomnia. There are times that naps are appropriate, but if you're trying to fix your sleep pattern, at first avoid the naps. Sleep restriction is the same. You get in bed, and if you're not asleep, get out of bed, and you have a strict wake-up time. There's this concept that people feel that if they're not going to sleep till 11 p.m., maybe if I go to bed at 9, I'll get to sleep earlier. But no, if you're used to getting to sleep at 11 p.m., instead what you're doing is you're building 2 hours of your bed, of associating your bed with I cannot sleep. So go to bed only when sleepy, and have a strict wake-up time. Sleep hygiene. I find that explanations are more important than instructions. Everyone's heard the instructions before, but sometimes we don't understand why. But when we go through this list, now we understand it. Light, okay, we want to avoid that because it affects our melatonin system. Environment, we want to associate our environment with sleep. Activity, doing too much activity is not going to allow your brain to slow down. Routine, have a particular routine that you associate with sleep. Put your pajamas on at the time of going to sleep. If your pajamas are comfortable, don't wear them all day long on the weekends, because then you lose that association. Napping. Now we know that long or late naps can affect our sleep hunger because it's like sleep candy. And substances. Caffeine can, past lunch, can affect our ability for feeling that tiredness there. So relaxation training is another type of treatment here. And I'll be talking more about this at Pediatric Grand Rounds on November 18, 2015, but it's not pediatric specific. And this is actually a picture of my kids there. And we do relaxation techniques and exercises at home. And this looks cute, but it's actually sleep avoiding behavior. If you see they're in their pajamas, I said, okay kids, it's time to go to bed. And they go, no Dad, we meditate. I'm going to do a little exercise. Randomly just kind of pass out some of these bubbles over here, okay? Sure. Thank you for, here we go. All right. And let's go ahead and open these bubbles up. Yeah. And let's do this 5 times. 5. Good job, good job. 4. What's the purpose of this? Just to have a good time. You got it. 3. 2 more. 2, and 1 last one. So, Dr. Uchowski, as you did this, did you think about your work day today? No? Okay. Were you thinking about sleep apnea or not sleeping as I was doing this? No? And I see a lot of people that their shoulders are a little bit more relaxed. I see that people are a little happier. You know, there's some smiles around there. I mean, yes, it was fun. We played around. But this was actually mind-blowing science. And what we have is calming the heart calms the mind. Now, if somebody is agitated, what do you feel your heart do? It races. And what does your mind do? Yeah, it races. So let's say that you're in bed and you're agitated that you're not asleep. What's your heart and mind going to do? Yeah, exactly. Well, just right now, we didn't think, we talked about how difficulty sleeping is a problem with clearing someone's mind, but we didn't know that we already know how to do this. So when somebody inhales, their heart rate is variable, but when you breathe out, the heart slows down. And if you take a minute and you're breathing out longer than you're breathing in, or you're slowing down your respiratory rate, your heart is able to calm. And when your heart calms, your mind is able to calm down as well. So does this really work? Well, has anyone in here been to a doctor before? Yeah. And when you were sick, did they ever write you a prescription, especially now with those electronic scripts? Have they ever written you a script for a chicken? No, but chicken soup makes you feel good, right? And I assure you, it's not the gluten or the high sodium load. It's hot. You have to blow on it. They say warm milk before you go to bed. Okay, then it should be illegal to drive and have a cafe latte. No, it's hot. You're blowing on it. That aha moment. Breath work has been incorporated into our society from martial arts to childbirth. The breath work is part of the foundation of yogic breathing, mindful breathing, even that 4-7-8 breathing that people commonly do. And it's a theory on why I have that it's difficult to stop smoking. I've never really met anyone addicted to nicotine. And if you think about it, I've seen people with nicotine gum or a nicotine patch pretty agitated on transcontinental flights or movies or stuff like that. Why? Because they're not having the exhalation, that process of passing the peace pipe from generation to generation. Some of the electronic cigarettes that they have, some of them don't even have nicotine in them, but it's the exhalations that are calming. And that's my theory on why it's hard to quit smoking. And because it's my theory, I know it's correct. So we hear a lot more about the mindfulness and what is mindfulness. And really, it's something that's hard to describe, but it's something that we just kind of experienced, that we were here doing the bubbles. We were in this present moment. We had a relaxation exercise. And evidence has been shown that mindfulness training can help with sleep. And this has actually come out recently that training someone in mindfulness is better than giving them just sleep hygiene training alone. And then also, mindfulness can be helpful both with acute insomnia as well as chronic insomnia as well. And if there's many different ways to get into mindfulness through books or whatnot, but I really do like this app. And this app is like $1.99, and it's called Calm, and it has some guided imagery, some guided mindfulness exercises. That's something that you may want to look into there. So how can this information today change my practice tomorrow? Understand that insomnia is not a night disorder, but rather a 24-hour disorder. There's things that happen all day long that lead to our difficulty with sleeping at night, and a poor night's sleep can affect us the next day as well. Now, sleep and wellness together. This is a wellness seminar that we've been talking about nutrition and about weight, and sleep and weight are intertwined. But sleep is important to keep our health importance, to keep to our health, our performance, our safety, and it's essential to our quality of life. Yet 40 million Americans suffer from sleep disorders. And during a week's time frame, 65% of people can have insomnia, 33% may snore, and 15% have unpleasant feelings in their legs. And this can cause problems with concentration, handling stress, listening, relating to others, solving problems, and even decision making. But these are all statistics, and what I find is that people don't react to statistics well. They don't relate to statistics. What they do relate to is money. And sleep-related fatigue costs U.S. businesses $150 billion a year from missed work, workplace accidents, or loss of productivity. People also relate to alcohol. And sleep deprivation can cause cognitive impairment just like that of alcohol intake. And they've done these stimulation tests where they give one group of people alcohol, another sleep deprive them, and the sleep deprived group, when they put them in car simulating rides, they generally do worse. And if you think about it, when is it that most accidents occur? They occur at about 2 a.m. So my little daughter, she's into princesses at 3 years of age, and she loves Cinderella, and I taught her that the moral of the story is nothing positive happens after midnight. People also know and relate to catastrophes. Well, Chernobyl, 3 Mile Island, Exxon Valdez, Challenger, all of these were catastrophic occurrences because of sleep deprivation. And one catastrophic occurrence that many people aren't completely aware of is if you saw the Star Wars movies, Anakin Skywalker, when he was going through his Jedi training, he actually had insomnia. And I really believe that when he was a young Padawan, if they would have read him my children's book, that he would have never turned to the dark side. And this affected generations of people to come. This guy has PTSD because he had friends on the Death Star. So I'm hoping tonight y'all can As you put your heads down on the pillow, start breathing a little bit slower. Make your airflow a little bit more silent, a little bit softer, and sleep great, because when you wake up, you can be as strong like a Wookiee. And now talking about weight and sleep, nutrition, weight, and sleep. This came out this very past weekend. Sleep doesn't waste time. It's good for the waistline. And sleep loss does equal weight gain. And this is through three main mechanisms. One, decreased REM sleep. Remember, our REM time is a very active brain time, and it's an active metabolizing time that we're burning calories. So if you have less REM, we're burning less calories during the night. Another are hormonal changes. When you have sleep loss, you have increased cortisol, decreased insulin sensitivity, and you have reduced leptin and elevated ghrelin. All of these lead to weight gain, as well as to increased appetite. And also increased snacking. When someone's not asleep, what are they doing? They're eating more. And specifically, what are they trying to eat? Foods that are higher in sugar. That's what they end up craving. And foods that, if you eat food that has a regular carbohydrate load or glucose, 90% of the glucose goes to your body. But some of the foods that you crave are things that are highly processed that have high fructose corn syrup. And this is sucrose, which is glucose and fructose seen in high fructose corn syrup. But fructose from that high fructose corn syrup only can be metabolized down into your liver. And you may say, liver, isn't that where the junk goes? That's right. And what happens is through biochemical pathways, names aren't important, but you can see the acetylcholine A, you end up getting these biochemical pathways where you get increased VLDL. What's that? High cholesterol. And you get these fat droplets in your liver, which causes fatty liver disease. And we have this disorder called non-alcoholic fatty liver disease that people don't understand why it's fatty, because they don't drink alcohol. Well, we just identified the culprit there. It's the sugars. And more happens. Fructose ends up getting going through other biochemical pathways where you increase uric acid. And when you increase uric acid, that causes inflammation onto your endothelial cells or your blood vessels, and you make less nitric oxide. And you need that nitric oxide to make your arteries nice and limber. So without that, you get hypertension or high blood pressure. And there's even more pathways that occur that we end up with insulin resistance. And insulin resistance leads to weight gain. And when we have weight gain, we have more sleep apnea. And catch-22 is when we lose weight, we can help with that sleep apnea, but if you have an untreated sleep apnea, it's hard to lose weight, but we can still treat that. But it's important to not let this pathway of insulin resistance occur. Now, nutrition is the new controversy. It used to be that when you go to a party, the last thing that you talk about is religion or politics. But now, when you go to a party, the last thing that you talk about is what you should eat or what you shouldn't eat. This is the new controversy. Now, before I talk about anything really controversial like nutrition, I want to talk about something less controversial, okay? Let's talk about ethnicity, culture, and race. That is so much less controversial than talking about nutrition, okay? Now, when you look at this picture, you may see some differences, but I only see similarities. My daughter here, she's part Puerto Rican, part Chinese, and thank God she looks like her mother. My niece, on the other hand, she's Puerto Rican and Jamaican. Do y'all see the obvious similarities? They're American. It's the American dream, baby. Part of the human race, and that's all that they know. So sometimes it's important not to take a look at, nitpick the differences, but to actually take a look at what's similar between them. So now let's take this controversial subject of nutrition, and let's say, hey, listen, there is no controversy. We can work together to individualize diets to be heart healthy, okay? Some people thrive as vegetarians, other people wither. Some people do great with meat, other people get sick. Some people have gluten or dairy intolerances that is beyond that of celiac or beyond lactose intolerance. You know, so some species were made to be obligate herbivores, others were made to be carnivores. And through millions of years, humans were actually made to be both. So there is no controversy. The right diet is one that is low glycemic. Control your sugars and you'll control your health. So when I do Cochrane database trials, I consistently see that low glycemic diets are ones that help people lose weight the best and maintain it over a longer period of time. Now the problem is that the standard American diet is very high in processed foods. And you look at this, and this is called a typical continental breakfast. However, on this continent, it leads to prediabetes. And some people don't want to hear about it. They don't want to see it. They want to forget that they saw this, forget that they heard it when they hear about controlling the sugars. And some people will forget about it because there's an increased incidence in what's being called type 3 diabetes or Alzheimer's. And what are kids learning about nutrition? It's important to talk to kids about drugs or sex, because if you don't, they're going to learn it from the TV or learn it from their friends. And what are they currently learning? They're learning that diabetes now has your family's name on it. And, you know, many times I see parents get very protective over their kids if they're exposed to secondhand smoke, but secondhand smoke is not the reason that this generation of children is going to have a lower life expectancy than their parents. And they did this study where they showed pictures of fruits and showed real fruits and vegetables to kids, and kids weren't able to identify them, but they were easily able to identify the junk food and sing their little jingles as well. Now, I'm not saying to never give your child a cookie again, but what I am suggesting is, hey, next time that you're at a grocery store and you give them that free cookie, make sure that they're able to identify some fruits and vegetables first. How many? Do their age. If they're 3 years old, pick out 3 vegetables. If they're 6, make it 6. They're also learning that American runs on sugar. But what are the things that we're doing for ourselves? Okay, in the morning before you leave, do you have your hot cup of coffee, and are you blowing on it with deep, gentle exhalations, calming your day down? Are you taking in the scent of that coffee bean elixir of life? Or are you out the door, stopping and getting a high fructose corn syrup latte that's the equivalent of eating coffee cake? So how are we going to get people to eat healthy, to reduce their sugar intake, to exercise, to reduce stress, to sleep more? Maybe we're asking the wrong question. What are you going to do to take back your health? All doctors and nurses and healthcare workers in here, take back our health. We are the gatekeepers of health, and own that. If you go back to one of my first comments, I said that it was hard for me to be a pediatrician when I couldn't give parenting advice. Well, I'm not suggesting that you need to have a brain tumor in order to be a good brain surgeon. What I am saying is that if we're not living healthy practices within ourselves, we're not going to be able to teach that to others. And the Latin root of the word doctor is teacher. Take back our health, see one, do one, teach one. And parents and family members that are in here, you are the gatekeepers of your child's habits and attitudes as well. So I'm very proud to be part of this profession of doctors teaching doctors that has gone over thousands of millions of years, that is more than, has gone longer than many generations of religions and the brotherhood. And I'd like to read 2 quotes from the father of medicine, of whom we've taken his oath. Let food be thy medicine, and medicine be thy food. And also sleep and watchfulness, both of them, when in moderate, constitute disease. So let's take action, take back our health. Okay. Also, this talk is being recorded so it can be placed on YouTube. I encourage everyone to encourage other colleagues to watch this. Why? Because this is not being taught in medical school. It is not being taught in nursing school, when in fact this should be taught in high school. And anyone who is watching this on YouTube or in the future, if you're seeing this, share this with teachers, share this with principals, and share this with school officials, because they are the gatekeepers of the minds of the next generation. If anyone wants to contact me, feel free to email me, jose.colon@leememorial.org. And I want to thank you all for your time, and just say that when we encourage others to encourage others, we make this world a better place. Thank you.
Amen.